formation because it's a supporting structure. It is not a contractile structure and is not made to stretch. So if anyone tells you that you need to stretch your IT, we're talking about the TFL and the IT band. If anyone tells you that you need to stretch your IT band, they have just shown their ignorance of anatomy. They're well-meaning.
Call them out, yeah.
I usually say nothing, unless they're a CrossFit coach who's being an asshole, and I just tell him that he needs to stop talking to me, because I've actually had that happen once. I was like, you need to stop talking, because I have a doctorate in anatomy, and you are a CrossFit coach. You took a weekend course. And there's nothing wrong with just know your, which just shows like just know what you know. Yeah. And so he was being a real dick about it. So if somebody says what they mean to say is to stretch your TFL because muscles can be stretched.
Right.
Yes. So that's what they're meaning. They just don't know it. Right. And so you can cause lengthening of tissues in the muscle, which is the TFL, which contributes to the IT band, which physically cannot be stretched. Now, there's more conversations that we can have about adhesions and whether or not it's sliding on this, but that's not our content today. So TFL doesn't do a lot.
Is TFL right underneath the glute medius?
No, it's in front of the glute medius and in the back. But does it come
Let's take a look here. So that's the TFL right there. I don't know how to get rid of.
Ooh.
Oh my God, it's so sensitive on it. So the TFL is that little guy right there, the one that's so red. Yeah. So that's TFL, and then.
So it's just superficial. Anterior and.
So that's glute medius there, glute max, glute medius. It's harder here.
So it's
dissect. And so glute minimus is underneath. There. Oops, I just took it.
So
minimus is TFL is anterolateral. Mm-hmm. The glute med and min are posterior lateral. Okay. Posterior and lateral. But the question that you're asking, I think, is about where they insert. It's harder to, not ilium.
We do?
You guys got a big picture of all this right behind you.
Oh, so sorry. Oh, all right. Sorry. Yay! All right, this is awesome. Okay, do you mind being our tech there, Chris? So can we look at the glute minimus insertion? Because I think what you're asking, is where is the insertions are commonplace. Like we have the TFL is inserting close to the greater trochanter. Yeah. The glute minimus is inserting near the trochanter. Yeah. So is the medius. Okay. So they insert similar places, but being as far as from a physics perspective, whether you're on the anterior side of a joint or a posterior lateral side of a joint, you have very different effects on that joint. Yeah. So we just started with the TFL as one of the hip flexors. What are our other hip flexors? So if we go, I wonder, can you look up hip flexors, Chris? So hip flexors in general, this big one here, do you remember this guy? Yeah, that's that tailor sitting muscle. And tailor sitting meaning your crisscross applesauce. And so that one does. And so do you see how if you look at it, it starts on the iliac crest and runs to the medial knee. And so if you just envision, if we make that shorter, it's going to bring your leg like this. So that's also hip flexor. But the straight hip flexor is going to be more your rectus femoris, which is this guy here, because it starts in that frontal plane, or the sagittal plane, and it runs across the knee, or across the hip, and across the knee. And so that, for patients, that is the one, and you see how it's aligned? It's going to be more straight hip flexion, straight. The TFL, being on the anterior lateral, is going to add a little bit of external rotation and abduction, but because it's little, it's not going to be doing as much. So what's really important about the rectus femoris is the vast majority of people that we see have tight hip flexors from our habit. We spend a lot of time sitting. And so what folks don't realize is creating muscle length through stretching is not happening.
When
You're not actually lengthening the tissues with a 30-second stretch. All you're really doing is reducing the neurological response that stretching is a threat and causing neuromuscular relaxation. So, you know, just the Golgi tendon organ, yeah. So so that muscle tightens because it's you know, the brain is telling it that that's dangerous. And so the best way to actually create lengthened muscle, first you have to get through the neurological alarm telling you that's dangerous, and then you actually have to spend a fair amount of time in that position. So if you actually want somebody to create, it has to be prolonged, comfortable, and static, or the best is dynamic.
Yeah.
And so the reason I'm talking about the rectus femoris and squatting is because that's the best way to lengthen the rectus femoris. If you have a tight rectus femoris, you have a multiple of issues that can happen. If your hip flexors, the primary hip flexor is the rectus, we'll just stay kind of with that, but understand that there's quite a few others, but the rectus is usually the one that's the most affected and the most that you can affect the most. So if the rectus is tight, it brings the pelvis forward into an anterior tilt. An anteriorly tilted pelvis then creates a fulcrum point in the low back and then creates a shearing force in the low back. And that's where folks, if their back hurts, you know, the most common posture is this. So they're doing this because if they straighten up, if their hip flexors are tight, if they straighten upright, that pulls their pelvis forward, creates the shearing forces in the low back, and increases their back pain. That's why they're here. And so that it accommodates into that hip flexion. So anyone with back pain, you should always try to increase their hip flexion, the hip flexor length. So the rectus femoris, since it crosses the hip and the knee, if the rectus is tight, you're affecting the anterior, posterior range of motion available to the pelvis, which affects the low back. And then that can also affect the other joint that it crosses, which is the knee, and puts a lot of pressure through the kneecap because the rectus comes down, comes over the kneecap, and inserts into the tibial crest. So you can get a lot of compressive forces through the knee because of a tight rectus. And so the best way to lengthen your rectus femoris is through dynamic activities and getting people to move. So get on down into a squat, all the way down. Think about your rectus. It starts at your iliac crest, inserts on your tibial plateau. This is actually a fully lengthened rectus femoris, even though the hip is putting it in a shortened position, but your knee is putting it into a fully lengthened position. Yeah.
But the pull from the knee
lengthens it completely. Yeah. So this, spending a lot of time in a squat position or in a variety of squat positions, actually, and from a myofascial perspective, dynamic activities will free up the fascia and the muscle and how it all moves together. And this can actually affect the IT band as well, because if you've had any swelling anywhere and are tight anywhere here, repeated movement is what's going to tease that tissue loose. So, yeah, the foam roller is nice and all, and some people think, I think there's a masochistic kind of male ego sort of mentality to more pain is more masochistic kind of pain is gained. But what do I'm not quite sure how smashing a tissue together is really creating lasting effects. It can be helpful for creating awareness of that body part. It can cause a little bit, but if you don't follow up with actual movements, you're not really doing yourself any good. So, foam rolling like after, a lot of times that's probably the best place to use it. So, yeah. Because you kind of just get the blood flow and keep things moving, but not to the point. It shouldn't be that painful, because if you cause pain, it turns the muscle signals off to that joint area. So just being mindful of that. Okay, so let's talk squats. So we have our basic squat, and the biggest thing to be mindful of, which we've talked about, is keeping the knees in line with the second toe. So this is not a good squat, because we're creating a lot of shearing forces in the knee. Let's talk about hip anatomy before we get too far down into squat. There is no perfect foot position for a squat. If anyone tries to tell you that your feet are supposed to be in a certain place, they're showing their lack of understanding of the complexity of anatomy. And they mean well. They really do mean well. I love CrossFitters. I actually rent a space at a CrossFit gym here in town. And so there's a lot of really great opportunities if you're in the right space. So here's your hip socket. Your hip socket is in your pelvis. So your hip socket is in kind of that between the sagittal and the frontal plane. It can be oriented it can have a different orientation. It can have an open orientation or a closed orientation. There can be a little bit of a tip in the frontal plane, but it's really usually more of that open or closed. Okay? It can be deep. It can be more shallow. So we've got these angles in the hip socket, and now we have the ball. So let's say this is the femur, and this is the neck of the femur. This is the ball of the femur, and it goes into the socket. So we have this angle here in the kind of the frontal plane. So we have this angle, and then we also have this angle that is unique to each human being, and it has to do with what you did when you were a kid and your hip joints were forming, and your genetics. So different genetic heritages have different proclivities, just like, for lack of a better way of saying it, how different dog breeds have different, if you have lineage that's from primarily one area, you just have different bony anatomy, you just have different anatomy. So you've got this angle, and this angle, and this angle, that all combine to your hip angle. And that all determines where your feet need to be when you squat. So that's a long explanation of why there's no perfect squat position. You can talk a little bit about width. A width recommendation that you can make is anatomical hip width, not shoulder width necessarily, or hip width. Usually women, if you say hip width, they do this because they think their hips are a lot wider than they really are. But anatomical hip width, if you're doing a squat that's not going to be weight, if you're not lifting something heavy, if we're just doing a basic squat, I'll cue somebody to be anatomical hip width, which is the middle of your bikini line here. Basically, that's your hip joint. And just as an aside, if anyone is complaining to you that they're having pain right in this region, specifically, especially if it's focal and sharp, that's probably a hip joint issue, and you might want to bring me into the conversation. Because that's just clear indication of a joint issue, intercapsular issue. Anyhow, that's an aside. So I usually cue somebody to put their feet in an anatomical hip width, because you see that also helps you to line your knees up with the second toe, which is where your knees need to be, because adduction is where you get into trouble. And that's from that glute med weakness or glute med lack of just use. And then just have the person, you already do this for your screening, you just have them squat without a lot of cueing and see what they naturally do. And then that really informs what's kind of going on and how you can kind of work with them from then on. So, anatomical hip width, and then see where their feet need to be with regard, and for them to be able to succeed. So see, for me, I'm able to get all the way down into the squat. So let's look at you guys. Come on down as far as you can.
Oh, anatomical, you said?
Just however, yeah. And so for Mike, what I'm going to look at, there we go. So you need a little bit of wider stance, yeah. And so kind of play around with that a little bit, because something else I would look at is if they're able to get into the squat but their heels are up, that's you more often because they have shortened tissues in their calf complex, and so you can screen that just by supporting the heel. So if somebody comes in and they come into a squat but they do this, it could be a couple different things, but the best way to screen as to whether or not it's range of motion, support the heel, and then if they are able to go into that full squat with their heel supported, that just tells you that they're limited because of the range of motion in the calf, and that can just kind of inform your other decisions from there. And so you can provide support that way. Because you want them, if you're doing squats, and a part of your reason is so that you can improve the length of the rectus femoris, and they're not able to get into it because of that ankle, then you can accommodate that. So a squat that's going to be loaded, you're going to want to have a wider base. How come? Exactly. You've got a wider base of support, you're going to be more stable and safer and more able to accomplish that. So somebody who's going to be lifting a squat, lifting a bar, or barbells or something, you're going to have that shoulder width. Okay, so here's our squat progression. We got our anatomical squat, or like just our basic squat, anatomical hip position, all the way down, back up. And then a cue for a lot of folks that they need is to maintain the muscle contraction throughout. What ends up happening to people is they come down as a passive movement. They just kind of fall into the squat. Their glutes are still asleep. They're not even turned on. And then they try to stand up, and it's harder because there's no energy in that muscle. Because what's the tendon supposed to do?
Oh, it lets you know, lets the body know it's safe enough to go deep.
Yeah, but it also stores energy. So if you're doing an activity fast, do you see that little bounce at the bottom? You lose it if you turn everything off, and now you're stuck down here. So encouraging people to, like you guys start early with the glute activation mindset. So if you say keep your glutes turned on as you're coming down, and then power up out of it, and then come down. Don't stay there. Power up out of it, because now you're really engaging that muscle group, and you're creating more of a dynamic movement pattern. So we have our basic squat. We've got our loaded squat with a little bit wider, and still working on that, keeping your knees kind of in line with that second toe. Okay. So how can we make a basic squat easier or harder?
Harder.
So we got that's good. So we have bilateral stable surface for squat.
So one leg.
So hang on, let's talk about eccentric again. What is the definition of eccentric?
I think it's traction while you're
so as you're going down into a squat, that is eccentric. Right? Yeah, so if you add more control to it, if you slow it down, there's going to be more of you're biasing that eccentric load. That can be something that you can look at. You can also add, kind of technically the progression is bilateral stable surface, bilateral unstable surface, because now you add some proprioception kind of stuff on there. I wouldn't be strict about it, because what that can tell you is if somebody's on an unstable surface, because I'm always thinking from a diagnostic perspective. So if you put somebody on an unstable surface So let's say they're squatting here, everything's great, they got no problems whatsoever, and the muscles are contracted in a simple way, and then you get them up here on an unstable surface, and you're having them do a squat, and they're all over the place. Now you just realize they've got some proprioceptive stuff. And so we're always looking at, risk for injury. So this might tell you somebody's at risk for, they've got some balance and proprioception stuff. But I think from an exercise perspective here, that's kind of fun. So we've got bilateral, stable surface, bilateral, unstable surface, and then we go to that conversation that we were just having. Think about your base of support. This is the easiest base of support because it's bilateral, stable. The next more challenging base of support is to go into a tandem stance. So now we go into our lunges, but in a way, we kind of skipped a whole bunch of stuff that we could be doing with a squat. Right? So what do we just kind of skip past that a lot of people forget? So we've got full squats. We've got loaded squats, so a squat like a goblet squat. You've got, if you're loading the upper extremities, then you're getting more bang for your buck if you're doing a goblet or a squat press you're just getting shit tons more work done, plus you're challenging them more. But we can also modify the squat itself. So we've got our straight squat. Yep, we've got our lateral. What would be? Technically this could be considered a side lunge. So we're adding movement to it, right? And that makes things more complicated. You can add more depth to it. But the squat that I think is the most forgotten is the curtsy squat. This one everyone should do. You should be doing curtsy squats so we do full squats, curtsy squats, and then lunges. Why? Why are the curtsy squats amazing? Okay, so the last couple times we've talked a lot about the glute medius and abduction, external rotation, and keeping the pelvis level, right? Now we're talking about squats for increasing the length of the rectus femoris and also the strength of the glute complex. But get into your curtsy squat, we're combining all of that in one movement. We've got balance, proprioception, lengthening of the TFL, lengthening of the rectus, and it's freaking hard. And you add, exactly, so that's the thing, don't forget, because people go from squat to lunge, and there's so many other options. So again, the same idea. We're stable surface for our squat. You can't really change the surface with a straight squat, but you can make a curtsy squat harder by increasing the length, and that's going to depend on how they can control. If they're crashing in here, if they're crashing in with a longer stance, then they need to shorten it up so they can keep that knee, because the knee needs to still stay vertical, the tibia needs to stay vertical, and that back knee needs to come down. So it's the same as a lunge, where you cue the person to bring that back knee down so that the front knee doesn't come forward. All right, climb on one of these. So this is how you progress a curtsy squat. You add some height to it. Come on there. Come on down, there you go. Here you go, Mike. Come on, do your curtsy squat there.
Yeah, Mike, you got one leg.
Oh, now that's a squat we're doing. Right? Yeah? So we've got a curtsy squat. And why is that so magical? Because we're combining the frontal plane and the transverse plane. We're combining that rectus and that whole glute complex. And how functional is this? People are doing lots of functional, you know, if the person is comfortable getting up and down, the thing is if you train somebody to be comfortable squatting down to get something, they're going to do it more during the day. That's what you probably have noticed. A lot of people who have weakness in their legs or balance issues, they just if they need to pick something up off the floor, they just pick it up like this. Because this is passive and requires zero strength. If they're comfortable doing a squat to pick it up, and you train them to do that, then they're going to squat functionally throughout the day, and then they're doing strengthening activities all day long. So we've got our straight squat, and you can add different loads to it, and then we've got our curtsy squat. So these are still static. So what's that? How can we then add some dynamics to the same combination of the musculature that the curtsy squat contains? A little bit like what you were just talking about. We were talking about that side. But how about if we add, like we were talking with Sydney last week, about the side, the dynamic, the side lunges. But from a curtsy squat, you're getting your pelvic stability, your glute complex, and your hip flexor complex strengthened here. So there's a diagonal component to this. How about we add a diagonal component in a dynamic fashion? So we have somebody come from standing and then landing diagonally, and then jumping and landing diagonally. So this is skate skiing or what's that? Speed skating. Some people call it like the Apollo Ono, you know, kind of thing. But think about, like, look at that. Try that. Try a few of those. The skate skis. And when you stick that landing, and what I love about this too is the balance perspective, the balance component of it. And to just have them, you know, just be thinking like 45 degrees, 45 degrees, 45 degrees, and you're really working what? Balance, strength, proprioception, all of that. And so that's all in the contents of the squat. So can you think of anything else that's before a lunge?
Before a lunge?
Can we do any rotation?
That's right.
With the squat? Oh, what do you think?
Yeah.
Let's think about that. In the curtsy squat?
Yeah. Anything? Is that safe anyway?
Well, I don't know. What do you think? That's hard. I like what you're saying, but I think because part of the beauty of the curtsy squat is the dynamicness of coming in and out of it, let's add the weights to the lunge, because a lunge you can stay in a static position and then add that upper extremity stuff. I think the lunge is more appropriate for that. But there may be somebody who's higher level to whom adding that upper extremity dynamic to the curtsy squat may be appropriate. But really, if you get them on a step and you're doing a curtsy squat, that's usually sufficient. So we didn't miss anything. All right, so then now we got squat in the straight plane. We got squat, a three-dimensional squat, which is basically what a curtsy squat is. So now we're remembering that 3 dimensions. So we're just adding layers of complexity. So now we're going to take out of the 3-dimensional, go back to more of that 2-dimensional into a lunge. Now, our cues for lunge is the front foot is forward. I always have people put their hands on their iliac crest so that they know where their hips are. First thing they do is you want them to bring their pelvis into full frontal plane so that the trailing leg their hips aren't open, that they have frontal plane pelvis. That back leg needs to be far enough back so that when they squat down, or so then when they lower down, the tibia stays vertical, and that's really critical. So the cues for a person to do a proper lunge would be get into a long step, straighten out your pelvis, and now lower your back knee to the ground. So then they're going to just go vertically. It should just be a vertical movement. If you say squat down or lunge down, usually people will do this, and that crushes the kneecap. Yeah, and so if you cue them, say, sit up, stand up tall, and bring your rear knee to the ground. And then you don't have to tell them about the front knee. It depends on the person. You might have to, some people don't require more words than others. But usually if you say, straighten your pelvis, lower your back knee. Now, here's something, if you want to talk about CrossFit. If you lower your knee all the way down to the ground, all your muscles turn off, and you have to turn them back on and get back up. So that's actually you're resting. If you put your kneecap on the ground in your lunge, you're taking a break, and you're resting. So that's actually cheating. So if you want to do a real lunge, that's hard. Well, it depends on what your goal is, and I think most of the time people don't realize that they're actually putting a resting moment in it. So for me, who's a purist, I'm looking at, like, if you're going to rest during your lunge, know that you're resting. Just be aware of it and just being intentional. But that's a resting moment in that lunge. Plus, you're crushing the kneecap. You can be creating a contusion, especially if you're on a concrete floor. But
it's harder to go from the lengthened position of muscles that way to versus coming down and going up, and you're using that elastic property of the fascia to come back up. Couldn't you argue that stopping at the bottom might make it harder to come back up?
Well, it's the same thing with the squat. It depends on, like, functionally, what is that doing for you? For one, like, why? If the ultimate goal is for the person to be able to manage more weight, which is like with the squat, if they turn off their glutes when they get here, they physically can't handle as much weight because the muscles have turned off. Now they have to re-engage them. And that's not functional because most of the time people are coming in and they have decreased use of the glutes. So the same thing with the lunge. If you train people to turn off when they need the most power, because you need the most power is when you're lifting your body weight up. So personally and professionally, my goals are to teach people to activate muscles, not turn them off when they need them the most. So with what you're saying, so just if you're going to let somebody rest, know that you're letting them rest. And you're putting them at risk for patellar contusion. and you're creating a crushing moment of the patella. And here's a random fact. The most compressive time in a squat for the patella is at 90 degrees. And so this is where PT has learned a lot. The original guy who did Chris Powers, he's in LA. He did a ton of research on patellofemoral syndrome back in like the early 2000s. Originally, he was saying only go to 90 to decrease the amount of compression, and then further research realized that that was actually the most compressive. We used to think that a full squat, ass to grass, was bad for your knees, but really it's the best thing for your knees because it lengthens your rectus. So, I mean, that's yay science. Always trying to second guess yourself or prove things. So just be mindful of what you're doing. If you want that person, I'm not really a fan. I think come down to 2 inches from the ground, just like in a V, when you're doing the boat stuff, the lower you are, the harder it is. If you let your feet, like if you're doing and I'm super weak, but if you're doing this, and you let the person just crash down and relax, and then lift their legs up, are they doing a V? Are they getting the core exercise? No, you're letting them turn the muscles off. So just know what you're doing. Okay, so the lunges are so much fun. We can add a lot of variation into them. So we got our lunge, we got our proper cues, and our cues are hands on your hips, straighten them out, bring your back leg down, back leg knee towards the ground, engage your glutes. Sometimes you'll have to remind them to use this muscle. So now we've got a really great squat, or lunge, right? So now we've got our staggered stance, this stable surface. The next logical, if we want to just go straight lunging, That next process to make it harder would be to lift the back leg and come into a Bulgarian split squat.
Oh, yeah, okay.
Oh God, I love how you guys just try to do something that was really hard. So what's great about the Bulgarian split squat, this is a little low, is I got it. Actually, the toilet is the perfect height. So let's do, I'll do the other one. I'll just grab this one. This is actually more comfortable on the foot. So what's fantastic about this, the Bulgarian, here, let's do this. All right, try your split squats. There you go. And you just have just the first part of your foot on there just for balance. What are you really stretching? On that right. Is that magical? This is the best thing to do. Somebody's in the bathroom, they're doing their Bulgarian split squats. So go ahead and give that a try, Mike. So that's just straight in the lunge category. There you go.
I just updated the title of Dr. Tonya Talks Squat to Dr. Tonya Talks Squats and Lunges.
Yeah, sorry. Well, I guess lunges are, because a lot of, we'll call this like a split lunge. There you go. So that's fantastic, right? So if you really want to get somebody to lengthen out so it's the lunge, first it's the squats, the full squats, then it's the lunge for getting that nice lots of biceps. Now let's talk about the lunge is a stable substrate upon which you can add a lot of variables, which is what you were just talking about. So for lunges, you want to stay stable first, and you can add all kinds of things. Like what?
Rotation, weights, all sorts of weights, arm flexion, abduction, abdominal.
Okay, I think I maybe gave you a lot. So we can do, let's be thoughtful about this. We're in a lunge. The easiest way to add rotation is to keep the weight, give me something, I guess, this pen. Don't have the easy one, haha. The easiest thing to do is think about your lever arms. We're in a lunge, we're static, we're keeping it here, and then we're just having the person just rotate. And then seeing if they can control their legs. Because the most common thing is for their knee to fall in. So cueing them, because they can't do anything harder if they can't maintain their position. So cue them to keep that front knee in line with the second toe with an uncomplicated torso movement. And the reason we're keeping it close is tactily, it kind of reminds you, because it's here, because people can really, if their arms are out, they can have their arms be moving different than because a lot of times you'll say, now rotate your torso, and they do this, and nothing's happening. So you teach them, here's how you rotate your torso, because you've probably noticed a lot of people don't move their torso and their hips separately. So this is fantastic. So get them to move in this way first. So we got a small lever arm. And then you increase the lever arm. You can have them out here and be doing it this way, and then what else? We were talking about here. This is where the cable stuff really comes in handy, the Palloff press. Let's see, we could talk about that Palloff press progression. Are you familiar with the Palloff press progression? Oh, okay, let's talk about it then. We don't want to have to move all that. We need to have it vertical. It needs to be horizontal. I mean, just horizontal. Vertical was just a word that came out of my face. Perfect. Which works better, Chris, for lighting? Here?
That will roll.
Huh?
That will roll. Over here, probably works one, actually. You can anchor it down.
I'm not going to be doing all that much. This will just, more people can do stuff. Hang on. Okay. So pal-off press, there's a ton of variations. The pal-off press is basically, your arms are straight, and you're in some type of a lunge position. Okay? Now, the most simple pal-off press is, this is usually more of a, you can use this for multiple things. This is really a core strengthening, lats, obliques, shoulder complex, etc. So you get the person here, this is the simplest because we're nice and supported, and you just get them to be rotating 45 degrees to neutral. 45 degrees to neutral. If this is too hard, which is often the times with somebody who's got a shoulder issue, you're not going to, we have to stay here, we can't. But so this is it. And then you just turn around, and then you can make it more difficult by adding the chops, but the pal-off press is just straight. So one, pal-off press, we're just staying in the transverse plane. So we're just here, 0, 45, 0, 45. Now, if this is for shoulder rehab, just an aside, if this rotation is too hard for somebody to do, you add straight arms, and you just have the person walk sideways. And then that's getting all their whole core. And this is helpful for those hyper-flexible people who have a lot of instability in their lumbar region, just teaching them to stabilize. So this is that stability on mobility, mobility on stability. This will train somebody to stabilize their proximal musculature. And technically this is mobility. We're moving, but we're creating stability here. So this is kind of a training wheels pal-off press. But then we come to, so we're in the lunge, and you're pal-off pressing this way, and you can modify that lunge however it is that you want with regard to, if you wanted, if you're still working on proximal stability, if you add an unstable surface, if somebody, and having them do it here, you're causing them to have to create more stability. And so the pal-off press, so then you can also, so the hardest pal-off press is where you're moving through this 45 degrees. The progression of it is, your arms aren't moving, your body is. And then we go to, you're in the lunge, and you're just it's isometric, because all you're doing is keeping the tension, elbow flexion and elbow extension, and this is all building proximal strengthening. And the last is this. If you have somebody do this and it's easy, you need to go to the diagonals. But if this is hard for them to maintain their control, go back to this, and then to this. Sometimes you just have to start here, because if it's a shoulder thing, we're usually here, add that complexity here, and then work to this. So that's your pal-off press. And a lot of times people start it down. This could be a baby step too, depending on that person. If they can't do it here, you could have them do it here versus this or this. Does that all make sense? Yeah. And just knowing kind of what your goal is. So let's see, what else? Can we do, let's do some of the diagonals in the lunging position. Probably. So real quick one, it's just the same ideas, because you have to leave, right? So our diagonals, it's the same thing. You come into your squat, and you go high to low, and then you can also do low to high. High to low, low to high. And that's going to change, and if you're having them do it,
Let me, never mind.
and the difficulty changes according to which side, which leg is in front. So this is less stable than this. So just switching which leg is in front. And then the next more complicated would be having a free weight, because this is actually providing a little bit of stability, because you're pulling, is a little bit of tension there. So then you can add, like you were saying earlier, we got our lunges and we're doing, so I think probably the biggest thing is, so now go ahead and do that lunge with the diagonal. So I think the biggest thing to take out of this is have a process. And, because now you're looking at all the different things in that lunge. So what's interesting is you did this, and then you also did this. Which one's easier? Yeah, and it teaches them that movement pattern. So first, if you shorten the lever arm, you're teaching them the movement pattern and how to stay stable. And then you have the arm straight, and now you created a harder exercise, but you've already given them the how to do it. And I think that's the variable that sometimes is missing, is people choose an exercise progression that's not as informed. Right? Okay. You gotta go? Excellent. What else? Does anybody have any questions on lunges out there in the cybersphere? Lunges, squats. Okay, that's cool. So good. Is this your phone?
That's fine.
Okay. All right, Mike. Do you want to be done, or do you want to do some stuff?
Can I have you assess my squats? Because every morning I get up and I sit on the toilet and my left knee pops. Oh, wow. And it's so I was thinking,
All right, let's see.
because one of the things that's been bothering me off and on for a while is my left medial knee. And sometimes when I just squat it's fine, other times not so much.
Sure. All right.
And it pops like, I don't know if it's my patella tracking the wrong way or...
Don't blame the patella. It's your femur that's the problem. The patella is just
I'm just making sure you're paying
it's
attention.
just a sesamoid bone. It's a victim. It's not the perp. Okay. Well, Mike, let me just see what you think.
Yeah.
I just thought I'd just let stuff.
Left knee pop.
All right, wait. You got to look from front. So scoot back a little. Stay out of the... All right. Go ahead. Do your squat however you do them. Okay, and then coming back up. Do that 5 times quickly. And let me know if you have any symptoms.
It pops every time.
Okay? So, but...
Really sore right through here every time.
Uh-huh.
Feel this whole just kind of locked down.
Okay, so let's see.
And a while back I asked if you do any assessment anyway, so I figured
All right.
you can help me
Yep.
figure out what's
Real
going on.
quick, do a single leg squat. Use that for balance. And you'll do both legs. We'll actually do the easy leg first. The non-symptomatic leg first. Hang on, let me get in position. Okay. All right, looks good. Oh yeah. How's that feel for you?
It doesn't pop when I go in like it.
Yeah. Okay, so hang on, let me get this camera. Mike, are you noticing anything?
When he was doing 2 legs, I did notice the left patella was acting differently. I was trying to see what it was.
It's not the patella. Look at the femur.
Well,
Okay, hang on. Hang on, let me get...
Something to do.
Okay, come all the way down and that single, for the right. Okay, and then flip and do the left. No, I hear what you're saying, Mike.
Yeah.
This is really subtle, but,
And another symptom is sometimes, maybe after the day after a workout, or if I haven't worked out in a while, sometimes I'll get a catch in it, or just turn and it'll like catch. For the rest of the day, it'll feel full.
Okay.
And the next day it'll be fine.
So if you remember the Thomas test, where you do here and lay down. Do you remember the Thomas test? I forget the names. All right. So this is a PT assessment, kind of, or ATC assessment. The orientation of the femur with the supporting surface, this angle here, tells us hip flexor specifically length. So this is hip flexor, and what's interesting is if we see the natural position of this knee being fairly extended, and the thigh is not comfortably on the table, this is telling me that we've got a rectus length issue. So now that I'm just going to gently add a little strain through here, and there's some pretty good resistance, I'm not going to push it. So now do you want to get your oculometer and just kind of guess about what angle this is right here? The knee angle? So this is 0, and then
Let's say that's shy of 90.
let's go with just 60.
Yeah.
Let's just say 60. All right, now flip and do the other. Let's see, maybe just for a better view. Go ahead and climb off so we can have the viewers can have the same view. There you go. Same thing. Yeah, there you go. So, so now we're looking just right away. We have more knee flexion naturally. The hip, the femur close to the table is slightly closer, but ultimately just when he was initially in this position on the other side, his knee was barely 20, and I mean we're 30 at least here. And if I add, I mean, just did you feel the other one? I should have had you feel it. So just if I'm going to add a little overpressure, just go ahead and relax. If I'm going to add a little overpressure, he can easily get to 90 without me doing a lot. And so I would say, so now go ahead and flip just for fun here. I would say that we just have, so subtly here, this hip, you see how the femur kind of rolls outwards? I'm exaggerating. As I push, we get the rectus femoris. Yeah, and so really, I think really what the biggest thing here is you've got a difference in length. So feel the difference between when you overpressure here, just gently. If you use your fingers, you'll get a little bit more feedback. You feel how you can feel things a little bit more? And see how that, just subtly, the hip wants to rotate externally, and then do the same on the other side. Just one more time, Chris, sorry. And then just watch. You feel how it's just subtly different, but that's enough difference. Yeah?
Yeah.
All right, cool. Sweet. So what are we going to do with you? Oh, let's go through our Pallof, not the Pallof. Let's go through our lunge progression. So we did our squats. We did the single leg squat. The single leg squat always gives you an indication about that pelvic obliquity, the pelvic stability. And so he had some pretty good, on the left, it was subtle, but it was not as much in the knee, but it was more in the pelvis, that dropped when you were loading that side. So, yep, yeah, so come on into a lunge. Now, is the left leg forward if we're suspecting the left leg? Is that easier or harder? It's going to be easier because that's a stabilizing leg. The rectus is getting super stretched here.
It's never like the back.
Yeah, exactly. So that means the one. No, do the left leg forward first. Do a nice lunge. There you go. Okay, and we're also going to look, Mike, kind of look here, in the front. Come and take a look here in the front. How's your knee feeling?
It's popping.
So go face. You want to? Yeah, because I just told you. Because so the tendency is to want to be here. There you go. So push into my hand here. How's that? Yeah, a little. Oh yeah, a little crunchy. Okay, now flip. Did you see that subtle medial rotation of the knee?
A little bit, yeah.
It's okay. Your eye will get better if you just, see how that's completely different?
Okay.
It just, like, if you just look at that overall movement pattern when he's on the right, he's just straight, true, and really, there's no bobbling, there's no hesitating, and there's complete control.
This is my no meniscus, no cartilage knee.
That's because you did a lot of, you protected it and then strengthened it. And that's been the support knee, and so it hasn't had, it's been doing static stuff rather than dynamic. So look at how, you can just see the overall comfort level of that. All right, so let's turn so that the camera can see that the sagittal sagittal plane difference, and we're looking at just that kneecap. There you go. See how straight and true that femur is. All right, now flip, and then always be looking at the foot too. Yeah. I mean, the instability as you're educating your eye, that should be a good clue for you. That instability, you'd be like, oh, let's look at that pelvis. Okay, great. Yeah.
It almost makes an X on that left knee.
And what's a nice diagnostic with this is if you just provide some resistance here, that creates this, you have to be careful. So push into my fingers. If you create a little bit of resistance, that creates an engagement of the glute medius complex and smooths out that movement pattern.
I've actually been doing those over the last couple of weeks as we've been talking about glute medius. When I've been lunging, is adding that resistance band.
That's off when you do that?
Yeah, so for you, just getting some, I think you're probably beyond this, so adding a little resistance here.
Feel more control.
Yep, so you're adding the control, and I really think also that, I'm going to ease you up on it, and I know these seem basic, but from a movement, sorry, I gave you the hardest one. But from a movement perspective, both knees. From a movement perspective, the squats with the band is just magic. It's just, you can't skip this step, even if somebody's super strong. You know, and so this would be something like, for somebody like Chris, I would have you do these multiple reps, like high reps, because this is technically a low load for you. And then, so from our electromyographical studies we looked at last week, having the band around your feet creates more glute medius recruitment.
More pain on the medial side of those.
Huh?
Popping in, there's more pain with this.
All right, so let's do let's shorten up the arc of movement. So bring your feet closer, and then just go halfway and see if that changes it for you. How's that feel? Yeah. So when you're doing the squat bands, you kind of need to only go 3/4, or like a halfway, not all the way to 90. You just stay in that first half, because it's about recruiting that glute med and creating that movement pattern where that knee stays in line with the second toe. So now put it around your feet.
Ankles or feet?
Just your feet. Yeah, there you go. And try to keep and push out against it with your feet, and now do your halvesy lunge. It's kind of a third lunge. See how that's different? Where this is the most different is when you're doing your monster walks, your side to side. So if you're quarter squat and you're doing your side, okay, let me show you. The proper way to do your side stepping is you start with the knees, because a lot of that has to do with that tactile feedback. So here's a proper squat. We kind of went off on a tangent, but not really. So if you're training a person to have engaged their glute medius during their functional activities, you've gone from the lunge, or the squat, which is, you kind of do like the third squat, like if this is halfway, is 90, go to about here, and that's usually the full range with the band. So you go to here, that's static with your feet. So then you add a dynamic movement pattern, which would be, and here's where people make a mistake. They'll have people do this, Well, you've lost all your muscle contraction. So you want to maintain the tension on that band the whole time. So you cue the patient, knee in line with your second toe, knee behind your toes. So you need to be able to see your toes the whole time, engage the band, and then stay and make little bitty, and get into a quarter squat, hands on iliac crest. Can you see your toes? All right. And if you do fast, little bitty movements, fatigue's a lot faster. Woo! This is hard. This is one that's worth doing. And then you can progress to a forward, and the monster walks is what people call it. And so that's around the knees is one way. And then being mindful with somebody like Chris, if they've got one side, if they're always trailing with the affected leg is doing less. So they need to be stepping, that needs to be the leading leg, but they need to do both ways. Because if you're stepping away from it, you're pushing with it. And you're teaching that pushing that you want them to eventually be doing. So the progression with these is here, and then doing some forward stuff, and then you can do some backward stuff. People forget to go backwards. And then put it around your feet and do the same stuff. This is where you get more glute medius. So the same thing. Immediately, right? Same thing. Same idea. You need to see your toes and have your knees in line with your second toe. And little bitty steps quickly, side to side. That's getting your glute med.
My right one is sitting here talking. Literally.
Right? So quarter squat. And your cue is they need to be able to see their toes. And they also need to have their knee in line with their second toe. Hands on hips. Little bitty steps. Maintain. So first you step out and get some tension. And now maintain that tension. Like a crab.
Oh my goodness.
Holy hell, right? Now this is worth doing. So this is specific to that movement pattern and those particular muscles. And if you can dress this up too, like if you want to make it a little harder, if the person, you could add some upper extremity stuff, but really in the squat progression, this stuff should be kind of done in that mix.
Yeah.
You got the full squat, but until they're able to fully control the little muscles and they're even, because Chris notices a really big difference one side to the other, until it's fully even, if you do more dynamic, more difficult stuff, their brain is going to turn off and protect that side that fatigues out really quickly. So ideally, somebody can really do a lot of this and they feel more even before you start adding. But I think what is fantastic about the curtsy squat is someone like Chris who has significantly different strength.
Squat scared the shit out of me.
Well, then let's do them.
Because they've always elicited symptoms with this knee, especially with
Yeah.
the original.
You're just not doing them right.
Yeah.
You're just not doing them right, that's all.
I do them from time to time, and I always feel vulnerable when I do them. They don't hurt. I always just felt like one wrong move it's going to be done.
Yeah.
I'm not confident.
And that tells you that your brain knows that you have a strength differential that needs to be addressed. So, Mike, which front, affected leg forward or affected leg back? Which do you think would be better for him?
I would say affected leg back first.
Yeah, try that.
So much more pressure on the.
So all you're doing, no. See, you make it easy on yourself. Just come on, step back, nice and shallow, a little bit and across. Have that front knee, and then just bring your back knee back. That's it. Just start with that. You okay? Mm-hmm. All right. Now try the other way. Try bringing your left leg forward. Just start shallow, nice and shallow. So bring your right foot forward a little bit. There you go. Make it a little easier. There you go. Is that manageable? It's a little bit terrifying.
It just feels unstable.
Yeah, because you are unstable. So your brain is smart. It's telling you don't curtsy squat because we're not prepared for it. But do you see how, so here's where we get into a little bit of psychosocial kind of psychology with patients or clients.
Yeah.
Having them do something that's modified, having them do something that's hard and modified can really be mentally fulfilling. So Chris is saying, I've always been terrified of curtsy squats. Did we have him do a full-on curtsy squat and reinforce that fear? No. We taught him how to integrate the muscles that are involved and then gave him a little baby one. We're not going to have him do this as an exercise yet because he's not able to do them fully. But we just primed in his brain the potential for getting fully better and to not be fearful of that movement pattern. Does that make sense? So sometimes people will get like in a little bit of a funk. They'll be like, oh, I'm never going to get better. And if you're like, no, you just look at you doing this curtsy squat. You're not telling them it's like a curtsy squat with like 4 sets of training wheels. It's still a curtsy squat, right? And so here, let's do the, I think for you, let's try that split squat, the Bulgarian. Yeah, try. Yeah. There you go. Woo. That's nice. And come on back up. Up. There you go. How's the tibia?
The right guy?
Yeah, vertical?
Yeah.
Good.
Good.
All right, now flip, switch. There you go. And sometimes if you have a little bit, I'm gonna. If you have just your forefoot on there. There you go. There you go. Feel that. How's that feel? Yeah. So we don't need to be doing the popping activities because that's just the tissue. The popping is just the tissues telling you that they're not long enough for that. But you can play around with that. What if you go halfway on that split squat?
Like halfway down?
Uh-huh.
Yeah, because part of me has just been like, it doesn't elicit pain, so I've just kind of been pushing through it when it pops.
Yeah.
Yeah, the popping is telling you it's not moving right. So this is just where that, this is,
Because of how hyper analytical I am about everything, it's just, every time it pops, it's like, what am I doing wrong? And so it never shuts off.
Yeah.
It never shuts off now. So every morning when I sit on the toilet, and some morning I get on, it doesn't pop, like,
yay!
9 times.
And then you never know why. Okay, so try to just have just your forefoot on here. There you go. You just have more. It's a little less stable, but yeah, if you go halfway, what does that do for you? So, Mike, come on back behind here. I just watch this. Look at his pelvis. Okay, and let's come now flip the other one to the other side. There you go. See how different the pelvis is?
Yeah.
Significant.
Now, I've had some kind of really acute, either herniation
Take a
or
picture
some
of this.
sacral injury, or I landed.
Yeah, the sacrum doesn't really get injured.
Well, I thought it was herniation, and we did all the assessments when I did the injury, and we thought it was L4, L5 herniation. So I've always had some kind of very, like, there's stuff going on in here, which I know I've adjusted over time. That was a long time ago. Periodically, I'll get a really deep spasm in there that'll sideline me.
All right, so get on in there. Let me show you what's going on. All right, scoot that forward.
I went deeper that time on the left foot. Maybe I'm closer, but I didn't have a problem.
You're just learning how to control your body. Okay, now do the other side. Just want to just show you your. There you go. Yeah. Beep, boop. Yeah. Okay, I think I got that. Okay, so really, you're just getting just some subtle asymmetry. So for you, just because you have such good body awareness, and like a typical person would present, because you've got rectus tightness and glute med I don't want to say weakness, but it is weakness. You've got, the glute med just isn't doing a lot. And so you're getting that subtle femoral pronation that's happening. But what's interesting with you is this isn't happening to the degree that is typical with somebody that has that strength impairment that you have.
Yeah.
I'm like this when I cook. I sort of clean on as I go.
No, that's all I have.
It's like the dirty tile. I already sprayed off the. Well, this is a perfect learning opportunity, Chris.
That's great.
Exactly what we.
I love these little sessions.
So with Chris,
Yeah.
what we typically see with people is a very obvious femoral pronation
Okay.
during the single leg squat. The person will just drop in like this.
Yeah.
But because Chris has pretty good body awareness, what he's been doing is keeping the knee in line, but the problem has been that because of that glute med on that side is so much weaker, the movement impairment is happening in the pelvis, which is harder for somebody to see. This is easy to see.
Yeah.
This is basically what he's doing,
Yeah.
but you're doing it in your pelvis. And so a lot of folks, if they see the knee in the right place, they're not able to see so much this, which is why you see that I had him do progressively harder things in a single leg stance and to further challenge this. And then we assess that, and just basically by what he was saying, it kind of told me what was going on. So, but somebody like him who, and this is where you get with athletes, they're able to cover up their weaknesses. Like when I was working with Olympic level runners in Eugene, and even we had the guy that I worked with, the PT aide had been shortlisted for the U.S. weightlifting team. He broke his neck in the Grand Canyon as a river guide, and then he was still, working with us. So we were doing Olympic lifting back like 2013. And so we get these high-level lifters, but they can't stand on one foot because they have such little glute med control. The same thing with the runners. And that's somebody like you. You're athletic and you have good body awareness. So instead of letting your knee come in like this, your pelvis is dropping. And so cue our conversations about that. Think about low back. Everyone ends up, the vast majority of people end up with low back issues at some point in their life. Once you get past into your third and fourth decade of life, most everyone's going to have an episode of low back pain.
I had it when I was a little kid.
Yeah, because you have a lot of mobility in your back. And I imagine you didn't just sit around the house and read books all day.
Well, I did read a lot of books, but I also...
Yeah, but you have a lot of mobility in your back especially, and so you have a lot of, like, there's a big fulcrum in your low back. Like, I can't move the way you move your back. And so that makes sense. So, but now we're just talking about those shearing forces of the pelvis being forward, and that's the shearing force just in that sagittal plane, because we're having this happen, and the tissues that are at this, or just, I wouldn't call it a hyperlordosis, you just have more mobility. Because hyperlordosis to me feels like a static, you just have more mobility in your low back. Like you have the availability of more lordosis. That's just semantics. But anyhow, so we create a fulcrum when that pelvis comes forward, and especially somebody like you who has mobility. So then the structures that are here are you get shearing forces, and that's what gets the back. So you've got shearing forces in this plane, but now when the pelvis drops, you're also getting that causes rotation, and that's what gets people. And so if you even have a subtle difference where you're getting a 5-degree drop of the pelvis, you're having an exponential increase in rotatory and adduction forces in the knee. So the femur, anything here, the femur is a lever arm. So anything happening here is exponentially increased through the knee, and the knee is not made for rotation. So anything happening at the hip adds rotation up and down, up before and after it. So you're adding rotation to the knee, which is tweaking out some of that tissue, and then you're adding that rotation in your lumbar spine. And it's not the, I bent over and picked up the feather and blew my back out. It was the decades worth of those subtle insults every time you load that limb.
Because I haven't been doing this, I've been doing this.
Yeah, you've been compensating with your pelvis.
So my
And,
straight with my pelvis.
yep, exactly. So that's what's happening.
That
So
full
it's,
feeling I get whenever I tweak it, that elicits it. Like I can literally feel that fullness in that medial joint line
yep.
that I get when that's just so.
Yeah, so you just have a really strong ability to
It's always that kind of like, feel stuck.
Yeah, and for you, this is one of the times where I would recommend doing some soft tissue work here at the victim because it's not flared up. The clicking tells you a couple of different things. It tells you there's some tissue restriction. So most likely the clicking has to do with the tissue is shortened, scarred down. It may have been injured and then healed up, not shorter. And so because it's not symptomatic, then that gua sha or the soft tissue work will be beneficial as long as you're adding lengthening activities so that you're controlling the healing process. So if you flare it up by pushing on it, see you later, Mike. If you get it moving and a little bit sore from the gua sha, but you're doing lengthening activities as it's healing, that's the whole point to that kind of focal soft tissue work. If you're doing the soft tissue work just in a vacuum and you're not controlling the healing process, you're missing out on most of it. So
What about pelvic stuff? Should I integrate some like
all the stuff we just did.
any kind of?
If you just do the, no,
I'm always pivoting through my getting that. Is there any? Would restricting some of that help to would?
I wouldn't overthink it and just address what we just talked about today. Just get your.
That's how it kind of correct itself when this kind of then I can start moving my pelvis a little bit more neutrally versus all.
Yeah, just strengthen your glute med and that movement pattern, and that'll take care of everything else. You know, if you want to do so from our electromyographic research from last week, which activities would you do to strengthen your glute medius?
I actually started doing the hip drop one.
The hip drop, the side plank is the most powerful.
Yeah, I was doing some of those.
Side plank, and you side plank on a box. We didn't,
With the elbow up or the?
with your foot on the box.
With my left foot on the box and my right leg hanging.
The dominant leg down.
Like this.
So the top leg is on the box, and now you're lifting your,
That.
yeah. And
I just feel so vulnerable.
yeah, so if it's a shorter box,
Yeah, I see what you're talking about. Well, you're like this. Just like something like this.
yeah. I mean, that's a lot.
Yeah, it's a lot.
But if you flip and you have your other leg up, flip it, but have both both legs straight. Oh, why am I putting it? Hang on. Let at least put something under your elbow. I know, but okay. So now hang on, come on. Get into a real plank with your hips straight. Now that's a plank. And so that's really, so start off with these. If you want to do a harder plank, do this one. And you could even do some repetitions where you lift it up. But this is, I would just, don't worry. You could create all kinds of crazy movement patterns. But that's a tougher plank if you really wanted to do something harder.
No, probably just but the idea here is to put stress or
glute med. It's glute med. So the side plank.
To pull up my pelvis. Because I was thinking that was more of the glute med working like a bridge support system here for my right glute med.
Don't overthink it. So the glute medius creates support for your pelvis when you're standing in this plane in the lateral, and it keeps it from dropping towards the ground on the. So whichever one is harder is the one you need to improve. So most likely it's the one where that affected leg is down, because the affected leg that's down is the one doing all the work. And then flip over to the right.
This one's already my right shoulder surgery.
Yeah. So you bring up a really good point. So that's for you, side planks are money because you're killing 7 birds with one stone. But here, let's go through my plank series, which is what I much prefer. Here's what I prefer for planks. So get yours out too, and I'll just show you. So I like a plank series. So you've got your hands underneath you, straight. So we start off here, and then we take one hand, bring it to the other elbow, switch to our side, and then take that front hand, bring it parallel to the other elbow, switch to the other side, and then come down to front, and then relax. So going from front, side is a lot more functional, and it doesn't allow you, it allows you to modify it. So ideally, a person gets to be able to do 10 seconds per position 10 times. That's super functional and applicable to the stuff you're going to do next, which is like, you know, whatever core exercises or standing stuff. But what's great about it is, like the static 1-minute planks, I guess I don't really know when you sit still for a minute in real life functionally, but it's more of an ego thing, the static planks. But it can really perpetuate improper movement patterns. And what's great about the plank series is, let's say you can hold it for 10 seconds here, but you can only do 5 seconds here, but you can do 10 seconds here. You can do that in that series. And so you just, when you start to shake and not be able to maintain the form, you just move to that next position. And so then you kind of even out that strengthening as you're going, rather than, you know, like, and it'll encourage a person to do more because they're already they're doing the easy stuff, and then they do the hard one for a second or a little bit, and then they go back to an easier position.
So you can start hard, do the easy, and on the hard.
Well, yeah, so like the front plank, yeah, so if it depends on the person. Like if the side plank to the right is the hardest, they might do the side plank left first, and then the side plank right, because then they're going to transition to the front and rest. You know, but whatever works. But I think that transition, because it's also, there's just a lot of motor pattern here happening here. You're controlling, you're staying in the right position. It's just a lot more functional as opposed to just 30 seconds. 30 seconds, you know what I mean? So,
I honestly never
I love
do anything past like 20 seconds because I get...
Yeah, and that's where the plank series is really beneficial. So and you give them a benchmark, 10 seconds times 10. And that's your goal, because ideally that is a functional amount of strength. And then you're going to have the strength needed. You're not going to get bored because you're moving. And you could even do plank series like in here, like as a rest, like in between exercises. So you're having them do some lunges or something, and then you do 3 sets of the plank series, like as a rest, and then add 2 push-ups or something like that. And so you can create more to that high intensity interval kind of stuff, or you can be using the plank series as a movement pattern reinforcer and a strengthener. But if you do fewer reps in between sets of something else, I mean, that could be something that you're doing. But ideally, they need to be able to have some evenness from one side to the other. Does that make sense? Yay!
All right, so glute medius and more movement and a little...
I would get one of these. I would put one of these in your bathroom.
Oh, so start from 6 up in the morning every day.
And then and you're doing, when you're brushing your teeth, you can get to about 100 squats for 2 minutes of teeth brushing. You got your band, you're brushing your teeth, and you're doing 100 squats first thing in the morning, and then you're doing your 100 squats last thing at night. And then you make it harder as you go, because that's where the toilet is perfect for a split squat. It's a perfect height, and you're going to be brushing your teeth anyways, You might as well do something useful.
So I need more successful repetitions versus.
High reps. Because you're got to get the motor pattern. Because the strength that you get first is the neuro-re-ed. Your brain is actually sending more signals to that muscle. That's the first amount of strength improvement that you get. You're not getting hypertrophy of the muscle. So high reps to get your brain and your body part talking. And then when you have more of those nerve endings firing, then throughout your day you're actually using that muscle more often. And then if you just add multiple bouts throughout the day where you're doing higher reps, and so, have this in the bathroom and maybe do, throw some of this around your feet, and when you're working with clients, you can just be like, all right, hang on, I'm coming, or whatever,
So
and
it's
so.
not an overuse issue, it's an imbalance, and once I start repeating the good patterns, then I'll start being able to, because one of the things I've stayed away from over the last few months is heavier leg days, like where I want to hold heavy weights.
Yeah, because you can't, because you don't have a framework upon which to add weights.
So I've avoided leg days, but I love legs. I love working on legs, but I haven't been able to lately.
Because you don't have the proximal stability. So once you get that glute medius, it's a strength issue. It's a motor pattern and strength, and whichever came, they came at that same time. So once you're feeling that you fatigue at about the same amount, one side to the other with the exercises that you're doing, the easiest is the squats with the band around your knees. The more harder are the lunges, the single leg, the Bulgarian split squats or anything loaded. Those are the harder stuff. But once you start feeling like you're having some strength equalization, then you can start adding some loads. But I would start adding loads, bilateral loaded with the goblet squat, bilateral loaded with the presses, something easier than throwing this on first. But I would use your barometer would be the band around the knees or feet, and your sidestepping and your side planks would be your biggest barometer as to whether that strength is evening up. And then once your strength is better, then you'll be confident. But yeah, the psyche is so into your neurological system, because your brain knows what's not safe.
Well, it's really fascinating, because I've been able, when I was, before COVID, when I was back out running, playing rugby and sprinting and stuff, no symptoms at all.
No, because you were strong.
No, but that was still having a clicking and popping.
Yeah.
Today, I'd still be.
Oh, sure.
So, but during activity, but I think with that kind of stuff, I've actually, there's almost these old patterns in me, because that used to be my dominant leg.
Right.
And I feel like when I play rugby again, it becomes my dominant leg again.
Right, of course it does.
And then when it's dominant, it no longer has as much of that imbalance. I feel like things work better, like that maybe those old patterns of that being the dominant leg are the better patterns for that leg, so it didn't pop and click and hurt.
Right.
So I get back into everyday life where I don't have to use it maximally.
Well, you probably, yeah, and that's where that threshold of strength kind of thing comes in. Is most folks, and this is the most obvious with older people, is we all have a functional threshold of strength. So this is if this is the amount of strength we need to be functional. Younger people are a function up here. We've got all the strength we can lose before we lose our function. Older people tend to be right here, and if one little thing happens, they come down here, and then it becomes apparent. So you probably were operating here, you lost this amount of strength, and then you just dipped below that functional level of strength in that dynamic. And so you were keeping yourself healthy by maintaining that neuromotor pattern, neuromotor connection, by doing the rugby and all that. And the reason you were symptomatic is because that side was still fatiguing out quicker, but it wasn't symptomatic because you had enough strength to keep it from being symptomatic, if that makes any sense. But it sounds like the motor pattern was still kind of there, but all right.
Thank you.
Whew, we did a lot. So next week we'll do shoulders. How's that?
I'm down with that. I can talk about shoulders all day
Yeah, shoulders are my favorite. So next week it's gonna be really hard, but we need to stay on track with just shoulders.